So when we hear the discussion of radiation to the brain, we hear two terms mainly. We will see the abbreviation SRS or HBR. Can you talk to what SRS is? Um, Especially the different machines that are used. We hear people talking about cyberknife and gamma knife and just a brief kind of explanation of what that is.
Sure, it's a great question. So SRS stands for stereotactic radiosurgery. What that means essentially is that there's focused radiation being administered to one or more parts of the brain, but it's targeted to a specific area rather than encompassing the entire brain, for example. The nomenclature can be confusing because SRS is typically thought of as radiation given in a single day to the brain, but that radiation can be delivered in multiple days when a single day is just not safe or viable. And a number of names exist for that. Some people call that fractionated SRS. Some people will call that SBRT, or stereotactic body radiation therapy. Some people will call that SRT, or stereotactic radiotherapy. But all of those refer to focused radiation given over more than one day, still to a limited number of targets typically. In terms of how the radiation is actually done, the specific technology, you allude to a great point. So there's multiple different technologies used to administer SRS or SRT, for example. There's gamma knife, there's cyberknife, there's linear accelerator-based SRS. There are new modalities like ZAP. But ultimately, one of the most important elements is not the technology that's chosen, especially for this reason, but rather that a team that's skilled in the delivery of radiation is overseeing the care. Because it's more than just which technology is being selected. Those differences tend to be relatively subtle. Some of the randomized data has told us that, for example, including an Italian randomized study that compared gamma knife versus linear accelerator-based treatment with really very little difference seen. But I think one thing we all would agree on is that you want to go to a center that has experience, that the given patient feels comfortable in, not only with the doctors, but also the nurses and therapists and other people who are involved in the care of that patient. And not just say that we're selecting one specific technological modality. So I think it's like driving a car. There's Toyota or Honda or Buick, and they're all fine cars. What probably makes the biggest difference on the road is who's the driver or drivers of that car. So that's how I think about it.
That's a really, really great analogy. I think in discussing, radiation with other patients, sometimes the focus really can be on which machine or which modality of radiation is best. Should I get cyberknife or should I have them do gamma knife? And what I'm hearing you say is it really doesn't matter so much which one is used, more so that you're comfortable with the team that is going to be utilizing that form of radiation to treat your brain metastasis.
That's well stated. I
Yeah,
completely agree.
really, and that's really interesting. So what about whole brain radiation? Can you talk a little bit to that, how that's different from SRS?
Sure. So with whole brain radiation, now the radiation encompasses the entirety of the brain. And so rather than treating individual tumors in the brain, the radiation covers the entirety of the brain. That includes the tumors that are seen on a scan. That also will include microscopic areas of disease. So microscopic tumors, meaning tumors that are so small that you can't even really see them on a scan. And the radiation encompasses everything. And while that sounds good in some respects, it also has some unique toxicities which have to be balanced, and I'm sure we're going to get into that later. But rather than a focused administration of radiation, Now we're treating the entirety of the brain. And I'm sure we'll get into this later. There are some spin-offs of that treatment that may allow certain areas to be excluded, but ultimately the entirety of the brain is being targeted. It's typically a treatment that's given not in one day, but between 1 and 3 weeks. When people do larger numbers of treatments, the dose per day typically falls. So it's roughly equivalent, whether it's 1 week, 2 weeks, 3 weeks. It's really up to the patient and the radiation team to work that out. And also other factors that go into that. How quickly does the patient need to get back to drug therapy, among other individual considerations. But yes, it's typically a longer treatment, and of course, treating the entire brain rather than individual brain tumors.
So when you're talking whole brain radiation, what about something, term we'll hear as hippocampal avoidance or hippocampal sparing? How does that fit into what you're discussing?
Sure, very great question, man. So I can share the screen, and sometimes a visual is helpful. You asked appropriately about hippocampal sparing whole brain radiation. And what that treatment is that the entire brain is treated with radiation with the exception of the hippocampi. And that's the plural for the hippocampus. There's one hippocampus on the right, and we also look at imaging backwards. So you'll see the mouse clicker on the left side, but we're actually referring to the right. So there's one hippocampus on the right, and there's one hippocampus on the left. And what you're looking at here is the right and left hippocampus. You're looking at an MRI in the top row, a CT in the bottom row. You're looking at different views. So the left is sort of a horizontal cut, and the center and right are up and down cuts of different natures. And what you're seeing is that the radiation dose, which is this kind of shaded cloud, doesn't include the hippocampus. It doesn't mean it doesn't get any radiation, it just gets a much lower dose of radiation than the rest of the brain does. And the reason that this is considered is because one of the most significant side effects of whole brain radiation is cognitive problems after treatment. And sparing the hippocampus can preserve cognitive function among such patients. This was proven relatively definitively in a randomized trial published by Paul Brown and colleagues a little over a year and a half ago. And what they did was they took patients who needed whole brain radiation, and they were randomized to receive either conventional whole brain radiation, where the hippocampus is included in the radiation field, or hippocampal sparing whole brain radiation, where it's excluded. And what they found was that there was better cognition, meaning better memory, better thinking in the group that had hippocampal sparing radiation. And it's important to also note that everyone on both the control arm and the hippocampal sparing arm, and that's another way to preserve cognitive function. And that was proven back in a 2013 study to be a benefit. So in patients who are candidates for hippocampal sparing whole brain radiation, it's advantageous to use it. Now the question comes about who is a candidate. So candidates are typically patients who don't have tumors in or near the hippocampus, near being defined as typically 5 millimeters or less, as well as patients who don't have leptomeningeal disease, and patients who can wait at least a few days before starting radiation. Because regular whole brain radiation can be started typically in a few hours or a day, but hippocampal sparing, because it's more complicated, typically takes longer. So if there's an urgent need to use radiation, hippocampal sparing probably isn't appropriate. But assuming those criteria and a few other rare ones are met, hippocampal sparing is a more advantageous way to give whole brain radiation than the historical way, which was conventional.
And so you were talking about the reason for avoiding the hippocampus for memory and cognition, and that made me think of a drug that's often paired with whole brain radiation. I'm not exactly sure how you pronounce it. I think it's memantine. Is that correct?
That is right.
Can you talk a little bit to that?
Absolutely. So memantine is a drug which is thought to help cognition, meaning thinking and memory, in patients who have problems in those domains who may not even have cancer. So that's where that drug started. And then about a decade ago, someone had the good idea of looking at that drug in patients with brain metastases who are getting whole brain radiation. So a randomized study was published by Paul Brown in 2013, looking at whole brain radiation with or without memantine. And the way the memantine worked was they gave it increasing doses over a few weeks and then kept people on it for about 6 months. And what they found is that in general, the memantine group had better memory function and cognitive function. People have spliced and diced this different ways, but the main take-home message was that memantine probably helps with thinking, memory, attention, and other measures of cognitive function after whole brain radiation. The obvious next question is, well, what are the side effects? They didn't see any bad side effects when they compared memantine to placebo in that study. Lower grade side effects is less clear, but there don't appear to be any significant side effects for the vast majority of patients.
So are you able to use whole brain radiation more than one time?
Yeah, it's a great question and it does come up a lot. So really, we want to try to avoid as best as possible repeat whole brain radiation. Because whole brain radiation given the first time can really have a lot of side effects. And then the idea of giving it the second time can be a lot for patients to tolerate. If it's absolutely necessary, it is an option. We have occasionally resorted to it. But there's a number of things to factor in. One is that when you give whole brain radiation a second time, you're often using a lower dose. So if tumors that were there at the time of first whole brain radiation have grown through that radiation, giving whole brain radiation a second time may be less optimal because you're often using a lower dose for a tumor that's often more aggressive. In addition, the toxicities can really be quite significant. More and more, rather than consider that treatment, we either maximize focused radiation or stereotactic radiation. We typically will really push the envelope with that because we want to avoid repeat whole brain radiation. Or increasingly in oncology, there's drugs that have, some degree of efficacy in the brain, and we try to really max out those drugs before resorting to another intense form of radiation. So this is an area that really needs more investigation. We don't know what's best, but we're really shying away from repeat whole brain radiation as best we can.
So you're looking at using whole brain. If you've had, let's say you've had a patient who has had whole brain radiation and they are present with more lesions, then you are looking more so at doing SRS again rather than whole brain radiation, or does it just depend on the patient's needs?
Increasingly, we're using SRS as much as we can. There's a couple of rationales for it. SRS carries more radiation dose than does whole brain. So although it's given over a smaller number of days, biologically, it's a stronger amount of radiation. So we've tried to utilize that a lot more without real upper limits in terms of the numbers that we're going to treat. If there are 100 tumors, it just is impossible. But we've certainly had cases where we've done 20, 30, 40, 50, 60 tumors if need be. And we utilize that most often if it's a tumor that was there at the time of whole brain and it grew through the whole brain. And the patient just doesn't have drug options to even attempt at that point. And they still want to pursue aggressive care after they talk with their families, nurses, doctors, other people who are involved in it.
So you were mentioning just about the number of tumors that you can, radiate the second time. What about radiating, making a decision between SRS and whole brain radiation, like the very first time a patient is referred to you, the number of lesions, how does that factor in just in your decision making between SRS and using whole brain radiation?
It's a great question. And most of the guidelines have focused on patients with a limited number of brain tumors versus a non-limited number of brain tumors and what's appropriate. I think we should be clear that all of the data until very recently has focused on patients with 4 tumors or less. And by all of the data, I mean like the highest quality of data which are the randomized studies. So there's been a multitude of randomized studies that have asked the question, can we use local therapy like SRS instead of whole brain radiation? Meaning, can we omit whole brain radiation? And the answer to that question is largely yes, as long as there's a limited number of tumors. Very recently, there was a study published in abstract form at the time of this recording of it that went up to 15 brain tumors, but that was a study out of MD Anderson. There were a smaller number of patients included. We're all eagerly awaiting that publication. And there are some ongoing trials that will test the question of how many metastases should we be thinking about with regard to SRS versus whole brain. I would add that it's not just the number, it's what drug options are there, how quickly are they developing? Is this someone who had no metastases a month ago and now has 15? Is it someone who's always had 15 for the last year? These are other factors to consider when weighing which treatment is most optimal.
So we spoke a little bit about the number of lesions that help you decide what's the best as far as whole brain versus SRS. What about looking at a lesion, say you've been referred a patient from a medical oncologist, and looking at them and deciding whether radiation is best or whether they need to be sent maybe to a neurosurgeon for surgery rather than radiation?
Yeah, that's another point that comes up a lot, Leanne. So I'm glad you asked about that. It's obviously important to have a multidisciplinary discussion about all options. And I think, we want to include the surgical team on all of these decisions about who should be going to the operating room, who could we get away with radiation with, or who might not need either, or just drug therapy, for example. But classically, the patients that we've considered referring to neurosurgery or who really would benefit from it concretely would be patients where there's diagnostic uncertainty in the brain, meaning like we don't know what is in the brain. We see something, we're not sure what it is, it's of a significant size, and we're not super thrilled about watching it. Because sometimes we see these little small areas in the brain, we just end up watching them. But if there's something like 2.5 centimeters in size, we think it could be an abscess or it could be a brain net. That's the type of patient that really needs to see a neurosurgeon again quickly. In addition to those patients, among patients who we strongly suspect have brain metastases, if patients are having neurologic symptoms, especially if steroids are not helpful or helpful enough, those patients should almost always see a surgeon because surgery is by far the best therapy to make symptoms go away quickly. And that can be important for patient quality of life. In addition, if there's a patient who has a tumor that's, bulky, 3, we pretty much refer all of those patients for a surgical evaluation because the likelihood of getting control with radiation is much lower. And often there's not a long leash to try a drug out because if there's swelling around that 3 centimeter tumor, that patient could quickly get a lot of symptoms and we don't want to have that. So we often will refer those patients to surgeons as well. And then lastly, if you look at the group of patients that have just like one brain tumor and there's nothing in the body, we see this occasionally in breast cancer. It happens more in lung cancer. Sometimes, even if it's just 1 centimeter in size, we'll refer to a surgeon, even if they're having no symptoms, because we kind of have wonder, and I say wonder because the data supporting this is relatively weak, whether taking that tumor out, radiating the cavity after, is more beneficial to the patient long term than just doing radiation by itself. So that's another softer reason that we refer to a surgeon.
So you just mentioned about radiating the tumor bed afterwards. Can you speak a little bit more to that? And because even when you refer for surgery, it seems that you are often involved in one way or another, even when they are surgically removed.
That's a great point. So, there's 2 factors to consider when someone has had surgery to remove a brain tumor, a brain net in this case. The question, should we radiate? And if so, how should we radiate? So the first question, should we radiate? There's a nice study out of MD Anderson by Dana-Farber Madgen and her colleagues that looked at the question: in someone with a resected brain metastasis, does radiating the cavity help? And it certainly, when it came to the likelihood that the tumor would grow back. And that's certainly one reason to strongly consider radiation. The thing with brain surgery is that it's a little different than having a mastectomy, for example, because their surrounding tissue is so vital that it's often difficult or even not recommended to remove everything in one piece with a margin of normal tissue around it, because you'd be removing normal brain, which nobody would recommend. As a result, there's often little cells left over at the cavity rim, even if you can't see them on a scan. And that probably amounts to about a 60 or 70% chance that a tumor would come back at that site if you don't radiate. If you do radiate, it lowers significantly. But this is where how should you radiate comes about. Historically, we've used whole brain radiation, even with one cavity. The data tells us we shouldn't really do that anymore, based on a couple of really good randomized studies that were published a few years ago. But then the question comes about, should we use SRS, like 1 day of radiation? Or should we be a little bit more broad with our fields and use like 5 days of radiation or 3 days of radiation? Where we don't have to give an enormous amount in a single day. We can be a little bit more generous with our volumes, and we can, ideally prevent recurrence in a safe way. Because essentially what the data has told us is as long as we hit the right target, the recurrence rates are pretty low. But when people have looked at SRS, the recurrence rates seem to be pretty significant. So really the answer that we're going to get to this question, SRS versus SRT, 1 day versus more than 1 day, will come from an ongoing alliance randomized study, which is accruing very well. And that'll compare SRS versus SRT to cavities. And I think that will be enormously impactful for the field. One thing to factor in, Leanne, and I'll share the screen again, is when we do cavity radiation, I think it's important to recognize that, a lot of the recurrence risk is along the lining of the brain. And I think this is where we want to be pretty generous with our radiation fields. So this is an example of a cavity. You can see the cavity in green. And you can see there's no white area around it. There's no contrast. But you can see these other nodules that develop afterwards, and they're circled in red. And this is tumor that's recurring along the lining of the brain. And this is something that we think complicates surgery in about 8 or 10 or 12% of cases, at least with a single institution series. That number can vary based on a number of factors. But when we design our radiation fields, we really want generous coverage of that lining of the brain to try to minimize the likelihood of the tumor coming back at the area that's the greatest risk. Now, that example I showed you, trying to include all that in a preemptive radiation field is too much. But I think the point is that we want a generous margin along the line.
And I just want to clarify that when you talk about the cavity, that image was showing where a tumor used to be. When you say cavity, you're saying that there used to be a brain metastasis there that you have removed, and so what is left is referred to as the cavity.
That's exactly right. So there used to be a brain metastasis here. There's not. It's just a cavity, and that's a perfect description of it.